Welcome to This Explainer, where we're going to decode the incredibly strict, and let's be real, pretty confusing guidelines around emergency department and critical care E&M coding. Look, if you've ever stared at a chart, just scratching your head, wondering exactly when an ED visit officially flips into critical care, or how on earth you're supposed to calculate those super specific time thresholds, well, you're in the right place. Today, we're breaking down the 2023 and beyond E&M coding framework to give you absolute clarity.
Okay, let's jump right in by following a hypothetical patient's journey. We'll quickly move through the ED coding framework and MDM rules, pin down the exact definition of critical care, tackle those tricky time thresholds, figure out bundled procedure deductions, and finally, wrap up with the strict guardrails for co-billing.
All right, Section 1, Emergency Department Coding Framework. Let's start right at the hospital doors.
So an emergency department isn't just your run-of-the-mill urgent care clinic or some off-site facility. According to CPT guidelines, it is a very specifically organized, 24/7 hospital-based facility designed for one main thing: immediate, unscheduled episodic care. Whether a patient walks in off the street or rolls in by ambulance, this specific setting triggers a foundational set of coding rules.
Now here's a massive curveball for you. That typical rule we all know, the one distinguishing new from established patients, throw it completely out the window. In a standard office setting, you have to obsessively track if a patient has been seen in that exact specialty within the past 3 years. But in the ED, there is absolutely zero distinction. The codes apply exactly the same way, whether it's their very first time walking through those doors or literally their 5th time this year.
Moving on to Section 2, ED codes and MDM rules. Now that we're securely inside the ED, how do we actually pick the right codes?
As we can see, ED services range from codes 99281 all the way up to 99285. Now, 99281 is a bit of an outlier. It represents minimal complexity and might not even need a physician or qualified healthcare pro at all. Think of a simple dressing change or clinical staff triage. But the moment you step up to 99282 through 99285, your code selection is driven strictly by one thing: the level of medical decision-making, or MDM. You're scaling all the way from straightforward decision-making for a minor sprain up to moderate for an asthma exacerbation and hitting high complexity for things like severe chest pain.
So here is the absolutely crucial takeaway. Time is never, ever used to select ED code levels. And why is that? Well, it's because emergency care is delivered on a totally variable intensity basis. An ED doc is usually juggling multiple encounters, darting between several patients simultaneously over hours. Because of this chaotic, overlapping style of care, the guidelines flat out prohibit trying to track dedicated time per patient for those base ED/EM codes. MDM is your one and only pathway here.
All right, Section 3, defining critical care services. Let's shift gears and ask, what happens if our patient takes a turn for the worse? Imagine our hypothetical patient came in with some standard abdominal pain. You've coded it as a standard ED visit. But then they suddenly deteriorate into septic shock, right? They need immediate, intense intervention. This massive shift in the patient's narrative bridges us directly into a whole new rulebook, the Guidelines for Critical Care Services.
Now, critical care has a highly specific clinical definition. It's the direct delivery of medical care to a critically ill or injured patient. We're talking about an acute impairment of one or more vital organ systems that poses a high probability of imminent, life-threatening deterioration. This isn't just monitoring. This requires constant medical attention and high-complexity decision-making to pull a patient back from the brink of a catastrophic outcome.
And this brings us to a brilliant concept: location neutrality. Critical care is a patient condition, not a room. A patient doesn't have to be physically wheeled up to the ICU to receive it. They can get it right there in the ED or a step-down unit. But, and this is a massive caveat, the provider must spend a minimum of 30 minutes of total duration providing this direct care. Hit 29 minutes? Sorry, you can't use critical care codes. You have to map it right back to those standard EM codes.
Which leads us perfectly into Section 4, Critical Care Time Thresholds. Assuming we hit that 30-minute minimum, let's tackle the math.
Okay, so the base code for the first 30 to 74 minutes is 99291. Simple enough, right? But what happens when you cross that 74-minute mark? Notice the wild contrast here. Under standard AMA CPT rules, you can slap on that add-on code, 99292, the second you hit 75 total minutes. Boom, 1 unit of 99291 and 1 of 99292. But CMS Medicare, they completely disagree. Medicare requires you to hit a full 30 additional minutes to bill that same add-on code. Under CMS rules, minutes 30 through 103 are just billed as 99291. You literally don't get to touch 99292 until minute 104. So yeah, knowing exactly which payer's rules apply is absolutely make or break for compliance.
Let's move to Section 5, Bundled Procedures and Time Deductions. Let's see how bundled procedures muddy the waters even more.
When you're sitting there calculating your total critical care time, you've got to remember that certain services are already baked into your critical care codes. We're talking about interpreting pulse oximetry, reviewing chest x-rays, cardiac output monitoring, gastric intubation, and interpreting blood gases. Because these are inherently part of codes 99291 and 99292, the time spent doing them is already assumed to be included. You absolutely cannot double dip on time here.
So, let's look at the formula for calculating your final billable time. Step 1. Calculate your total direct care time. Easy. But step 2 is the trap that catches so many coders. You have to absolutely deduct any time spent on separately reportable procedures. For example, if a physician spends 20 minutes doing CPR or dropping in a central line, which remember, have their own distinct CPT codes, that 20 minutes must be carved right out of your total critical care time. Only after making those strict deductions do you arrive at step 3, your actual final billable critical care time.
Almost done. Section 6, co-billing and final guardrails. Let's talk about the strict rules for co-billing these on the exact same date.
As a general rule of thumb, you cannot bill an EDEM code, like a 99285, and a critical care code for the exact same time period. They are completely mutually exclusive, but there is one major exception. You can co-bill an ED visit and critical care on the same day if, and only if, the initial ED evaluation was fully wrapped up and completed, and then, later that same day, the patient's condition just suddenly tanked and deteriorated, demanding critical care.
And that scenario leaves us with a pretty vital question to ask your clinical teams. Is your documentation actually precise enough to prove this? Could your charts survive an audit right now? Can you prove exactly how many minutes were deducted for that central line? Do your notes definitively show that the ED evaluation was fully completed before the patient crashed? Look, in the high-stakes world of EM coding, vague timestamps and generic condition updates are literally the fastest track to a denied claim. Mastering these frameworks is an absolute game changer for accurate reimbursement and compliance, but it takes relentless attention to the details. So, ask yourself, how much revenue is your facility bleeding right now simply because of vague timestamps or mixed-up CMS rules? It might just be time to audit your own workflow. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.